And I'd like to thank the organizers for inviting me to speak on a subject which is very dear to me. It is management of patients with diminished ovarian reserve. I will do my best to use terms which will be simple and easy to understand for patients. Whatever questions you have, I will do my best to answer them during the QA session. So the first thing we are going to do is define what is diminished ovarian reserve. I will then talk a little bit about the different ovarian reserve tests, especially measurement of AMH levels, and the various indications for ovarian reserve testing, and also where ovarian reserve testing should not be done. Regarding the second half of the talk, when it comes to getting older women pregnant, Dr. Gautam Allahbadia is going to be speaking on it today. So I will not be speaking on the actual treatment details on these patients, but just give a brief summary and then let Dr. Gautam take it from there. So what is diminished ovarian reserve or egg factor? This is a term that is used to define a woman who has fewer eggs in both in terms of number as well as quality. And these women will respond very poorly when we stimulate them for IVF. What needs to be understood is that diminished ovarian reserve is different from menopause or premature ovarian insufficiency or premature menopause, because these women will quite often have regular periods, be very healthy, fit, exercising, but when we do the tests, we realize that their ovarian reserve is diminished. The other fact which I would like you to remember is that age is an independent variable that must be considered. To give you an example, if you have a 20-year-old versus a 40-year-old patient, both of them could have the same ovarian reserve test results, but the 40-year-old will not do as well as the 25-year-old with the same ovarian test results. So age is an independent variable that must be considered. Other things that impact ovarian reserve include genetics and environmental variables, something which we will be talking about. So this ovarian reserve testing started when I was doing my fellowship in Norfolk, Virginia. At that time, Richard Scott was my co-fellow there. And what they found out that on cycle day 3, when they measured FSH or follicle stimulating hormone levels, when these levels were elevated, the pregnancy rates were low. So they divided patients using assays at that time into 3 groups. FSH level less than 15, those between 15 and 24.9, and those when the FSH level was more than 25. As you can see, those days, the pregnancy rates were pretty low, but even with low pregnancy rates, they found that when the FSH levels were elevated, the pregnancy rates were negatively impacted. At that time, there were other blood tests that came out. There's a Clomid challenge test. There's a GnRH agonist test, also measurement of inhibin B. But since I have only 20 minutes, I will not be discussing those tests. Then came the use of ultrasound for assessing ovarian reserve. And this is something which I do with all my new patients when I see them the first time. We do a vaginal ultrasound and take a look at the ovaries. And if you look at these 3 images on the right, the middle ovary, if you look at it, we look for those little black circles inside the ovary, which are called as antral follicles. So the middle ovary has hardly any antral follicles. the one at the bottom, if you look at it, 1, 2, 3, 4, 5 antral follicles. So this is a normal antral follicle count versus the ovary at the top is a polycystic appearing ovary where there are more than 12 of these antral follicles. So this is a patient with a high antral follicle count. So these are little black circles measuring 2 to 10 millimeters in diameter. And we do an ultrasound, take a look at an ovary on day 3 of the cycle and get a very good idea about the patient's ovarian reserve. A low antral follicle count is associated with a poor ovarian response during IVF stimulation. This test can be difficult to measure in obese patients, and there are some intercycle variability. But then comes a test which is now the mainstay for assessment of ovarian reserve. Currently, it started about almost 20 years ago, but we are now measuring AMH levels routinely in all our patients. So this is a glycoprotein that is released by the cells that surround the egg in the ovary. And it has got a role locally, which I'm going to explain to you in a minute. But basically, AMH gives an idea as to the number of eggs that still remain in the ovary. When the AMH level is low, and we will see the factors that cause low AMH levels in a minute, the outcomes are relatively poor. So what are the factors that impact AMH levels? And instead of going through the entire list, I'm going to emphasize the 2 or 3 main ones that impact AMH levels. A very common diagnosis when the ovarian reserve is elevated is polycystic ovary syndrome. Under other causes of decreased AMH levels include patients who have been on birth control pills for a long time, patients who have been on GnRH agonists. Those are medications we use to suppress the ovaries. These will reduce AMH levels. Obese patients quite often will have reduced AMH levels. Patient with a history of ovarian surgery or endometriosis will quite often have reduced AMH levels. It makes sense. If you've had surgery on the ovary where they've removed ovarian tissue, that's going to mean there are fewer eggs remaining in the ovaries, resulting in a low AMH level. So which leads to the next question is, what is a normal AMH level? And this was a table that was published almost 10 years ago, and it's a little bit busy, but if you look basically, as age increases, the AMH levels will drop. So if you look at this 25-year-old, the mean AMH level is around 4. But when you look at a 40-year-old, the mean AMH level is 1.1. So here's a simple way of remembering at what age group, what should be the AMH level. But if you want to remember just 2 numbers, then the cutoff I use is 2.1. If it is 2.1 or higher, then that's a normal AMH level. If it is less than 1, then you have a reduced AMH level, confirming a diagnosis of diminished ovarian reserve. So this is a busy table, and it shows a comparison of the 3 techniques that I just mentioned, measuring basal AFH, antral follicle count, and AMH levels. So as you can see, the earliest changes you'll see when ovarian reserve is decreasing will be with AMH, then will be antral follicle count, and then the FSH level will start going up. Each one of them has advantages and disadvantages, but basically the one which is a mainstay in clinical practice today is the AMH level. After that is the antral follicle count, and the FSH level shows a lot of variations between cycle to cycle. And also it has to be measured on day 3 of the cycle, or rather day 2, 3, or 4, meaning in the first few days of the menstrual cycle for it to be accurate. But most practices, I think, today are still measuring all 3. So here's a very simple way of explaining why low AMH levels are associated with diminished ovarian reserve. A woman is born with all the eggs she's ever going to have. And when a woman starts getting periods, there are about 300,000 eggs. In a reproductive lifespan, a woman will ovulate around 400 times. So there are hundreds and thousands of spare eggs that are there. However, a woman will lose about 1,000 eggs every month to a process which is called as apoptosis. So if whether she's pregnant, on the pill, getting periods, not getting periods, a woman loses about 1,000 eggs a month. And as she gets older, she will lose even more eggs. So the question is, why does she lose only 1,000 eggs? Why not 2,000, 5,000, or 10,000? And that's where AMH plays a role. So AMH is the local regulator in the ovary that prevents more eggs from going through what's called as programmed cell death or apoptosis. That's why when the AMH level is low, the woman starts losing more and more eggs. And that's why low AMH levels are associated with diminished ovarian reserve. This slide here shows the various stages of development of an ovarian follicle. And as you can see, AMH is affected by the earlier ovarian follicles. Then comes AFC, the antral follicle count, and finally the FSH levels. So basically these 3 tests all will complement each other. Now at InVia Fertility in Chicago, we have been using this lab in Boston called ReproSource. And we have been drawing day 3 bloods and measuring these 5 hormones: FSH, LH, estradiol, AMH, and inhibin B. And they have an algorithm with which they come up with what's called as the egg retrieval score, where 11 is a good number. And in this patient, for example, the egg retrieval score was 9. As you can see, the AMH level is borderline and the FSH level is also borderline. So I found this to be very, very useful in my practice in terms of predicting ovarian response and also planning the stimulation protocol and individualizing it so that we get the maximum response from that particular patient. So what are the indications for ovarian reserve testing? Of course, they are now a routine part of infertility evaluation. As I said earlier, they can be used to plan ovarian stimulation protocols. If somebody, for example, is having irregular periods or not getting periods, you can do these tests to assess the ovarian reserve. AMH levels are not a part of the diagnostic criteria currently for diagnosis of polycystic ovary syndrome. But generally speaking, patients with polycystic ovary syndrome will have elevated AMH levels greater than 3.5. In women who are considering freezing eggs, AMH levels gives an idea as to how many eggs they are going to produce, so that we can advise women as to how many eggs we are going to get. And sometimes they need to go through more than one cycle of social egg freezing to maximize the chances that they will have a baby when they're ready to have one. Of course, ovarian reserve testing is done to assess egg donors. When somebody comes to our clinic as a potential egg donor, we will do an ovarian reserve test as well as an antral follicle count. And a combination of those two are used either to choose or to reject a potential egg donor. Ovarian reserve testing can be assessed to look at how the ovarian function is before and after patients who have undergone chemotherapy for cancer. It can also be done to assess ovarian reserve before and after surgery in reproductive age women. And there are other indications that are not part of the scope of today's lecture. So to repeat, when the AMH level is less than 1, it predicts poor ovarian response in patients who will undergo IVF, and they will usually produce less than 4 eggs. And Dr. Gautam will be talking on the different protocols that he uses to try and get as many eggs as he can from these patients. When the AMH level is normal, then we just generally use a stimulation protocol, which we use for normal responders, and these patients will do well. In patients, when the AMH level is high, we worry about what's called as a hyper response or ovarian hyperstimulation syndrome. To these patients, we will use a gentle stimulation, and there are a lot of other tricks we have to minimize the risk of ovarian hyperstimulation. The next point I'm going to make is very, very important, and this is something which I'd like to really be one of the take-home messages from today's lecture. And the question is, can these ovarian reserve tests be used as a fertility test? I mean, when you go and see your OB/GYN doctor, they do a pap smear, they do a mammogram, they check your cholesterol. So can these tests be used as a fertility check? Let's say somebody who is 30 years old, who's not quite ready to have a baby. Can she just go to the doctor, have these tests done, and does that predict as to who will and who will not achieve pregnancy? And this was a very important paper that was published about 4 years ago from a group at the university in North Carolina. And this slide is a little bit busy, but the question is diminished ovarian reserve as measured by low AMH levels associated with infertility among late reproductive age women? And what they did is they looked at 750 women and did AMH levels and then followed them for the next 6 to 12 months. And the findings were really very interesting. There was no correlation between low AMH levels and who got pregnant and who did not get pregnant. So it is not correct to draw AMH levels as a fertility test, because a lot of these women will then have unnecessary stress. And then we see them in our office where they come in and say, listen, I mean, what am I going to do? I'm 30 years old. And then they are advised egg freezing and things which are truly may not be necessary. So AMH levels are not to be used as a fertility test. They are useful in patients who are infertile. They are patients when it comes for a fertility specialist to decide on what would be the optimal protocol for stimulating a patient, and they should not be used as a fertility test. So what can be done for patients with diminished ovarian reserve? And this is where I'm going to summarize. You can have a conference on this, but I'm going to summarize in a very short period of time. Basically, in younger patients, you could try 3 IUI cycles, intrauterine inseminations. But in older patients, greater than 35, definitely greater than 38, in vitro fertilization is the way to go. These patients are basically, their biological clock is running overtime. they have diminished ovarian reserve, they are going to produce few eggs. So in vitro fertilization has the highest per cycle pregnancy rate compared to any of the other treatment protocols. So we are very aggressive, especially in women above age 35 or 38 for that matter, in terms of going directly to IVF and trying to get them pregnant as soon as possible. Some of these women are having only their first child. So quite often we will do what is called as embryo banking, where we will do more than one cycle and then freeze the embryos so that when they come back for their second or third baby, we will have younger embryos with which we can help them achieve pregnancy. What about adjuvant treatments? Are there any medications? Are there any drugs? Anything that can be given? And the few that, I mean, of course, all these patients are on prenatal vitamins, but currently at InVia, we have been using CoQ10 in a dose of 600 milligrams daily as an adjuvant. Low vitamin D levels are associated with low AMH. So we have been measuring vitamin D levels and treating them with vitamin D. DHEA, androgel, testosterone, these have been used. But again, that's a different lecture by itself. But the bottom line is that there are some adjuvant treatments that can be used to help in these patients. Obese patients with low AMH levels, if they lose weight, then that does increase their fertility. So in conclusion, AMH level is the best test for assessing ovarian reserve. An antral follicle count is also a good test to assess ovarian response to stimulation. FSH levels have low sensitivity, but a good specificity for ovarian response. Age is an independent variable that must be considered. Other factors that decrease AMH levels include obesity, smoking, ovarian surgery, birth control pills, GnRH agonists, etc. Factors that increase AMH levels, the commonest one to remember is polycystic ovary syndrome. And there are indications for ovarian tests as a part of infertility evaluation and treatment and those considering egg freezing, but it is not indicated as a fertility screen in patients who are not trying to conceive. Thank you.
Thank you, Vish, for a wonderful presentation as usual. I will finish my presentation in about 20 minutes and then we'll take the questions together. As per the rules of this webinar series, we will only answer questions put in the question and answer box. I will now share my screen and start immediately. So I practiced in India before 2012 and patients with even AMH less than 1.5 were being pushed for donor egg IVF. And then in the U.A.E, we work under Sharia and there is no third-party reproduction at all. And we work routinely with 45-year-old patients to give them their own genetic children. So it's a different perspective. And I got a chance to practice my favorite subject, minimal stimulation IVF and accurate accumulation and vitrification of blastocysts with the help of Pgta. Today, 95% of our cycles in the U.A.E are with Pgta, and we have pregnancy rates in excess of 70% and clinical pregnancy rates in excess of 70% and live birth rates in excess of 60% routinely, even in this poor prognosis age group patients. Today is the era of individualized controlled ovarian stimulation. Everybody uses the flexible antagonist protocol. And how do you individualize stimulation? Basically, with age of the patient. I'm going to show you a slide as we talk towards the end of the lecture, which shows us the distribution of euploid embryos when you correlate them with age groups. So these four things are decided when we individualize controlled ovarian stimulation. Age of patient, AMH, normal AMH is 3 to 8 nanogram per ml. antral follicle count 5 to 7 in each ovary, and previous ovarian response. If she has had failures, we have her sheets, then previous ovarian response. So let us focus directly on our interest group, women above the age of 40. Usually their AMH is less than 1.5, AFC is just 1 to 3 per ovary. Usually, when you look at their history sheets, 1 or 2 day 3 embryos have been transferred in previous failed IVF ICSI cycles with the conventional flexible antagonist protocol. And the clinical pregnancy rate, even in our hands when we were practicing the same thing, was only 20 to 25% in most units. If you read the literature, clinical pregnancy rate is 20 to 25 and a very high miscarriage rate, abortion rate thereafter. Today, after a long journey from 2010, which started in Osamu Kato's clinic in Tokyo, Japan, mild ovarian stimulation protocols such as protocols such as IVF Lite have several potential advantages over conventional hard IVF protocols, including drastically reduced medication, producing fewer eggs, but eggs of higher quality. Today, patients are not denied treatment based on their day 3 FSH value or ovarian reserve. Routinely, we get patients with FSH 20 or more than 20, yet very acceptable pregnancy rates are achieved with remote frozen thawed embryo transfer. And contemporary peer-reviewed published results from 4 continents strengthen the argument for IVF Lite today as an alternative to standard conventional stimulation protocols. Our group strategy, both in India and UAE, and some friends practicing in Europe and North America, employ Pgta in selected patient groups where day 5 biopsied cells are tested for ploidy using next generation sequencing to select a single embryo for transfer in a remote thaw cycle. If there are doctors in the audience, they can read these editorials, one for the IVF Lite Journal and one for the Indian Journal of OBGYN, which gives you a lot of references, recent references. Routine IVF is being challenged by simpler methodologies in the 40+ age group. What should patients and doctors know? What is challenging conventional IVF? So it's always modified natural IVF, minimal stimulation IVF, and IVF Lite. IVF Lite combines the advantages of all the protocols used in older age groups, and like I've told you, in our hands gives us 70% clinical pregnancy rates. So minimal stimulation IVF plus accumulation of vitrified and biopsied blastocysts. So what we do is each cycle, we grow the embryo to a blast, we biopsy on day 5 a few cells, the biopsies are frozen and the blastocyst is vitrified. And we do this till we reach a cutoff figure. So based on our experience, our cutoff figure is 6 blastocysts. If some AMH is less than 0.5, then we bring down the cutoff to 4 blastocysts, 4 biopsied blastocysts. And then we get, once we send the 6 or 4 blastocysts, depending on the AMH, we get 50 or 60% normal if you use Clomid-based protocol. So what is a minimal stimulation IVF? Where a stimulation regimen is where you use less than 1000 IU of gonadotropins, and a stimulation where we use clomiphene along with a combination of less than 1000 IU of gonadotropins. In both the protocol, GnRH antagonist is the cornerstone. Like I told you, the story began in Tokyo. I went to Tokyo, spent time there, learned from Dr. Kato, came back and started IVF Lite in Rotunda, Mumbai. And this included embryo accumulation and vitrification, which we call AccuVit. At that time, our inclusion criteria was only patients less than 44 years old, at least one previous controlled ovarian stimulation cycle with poor response. So Kato was mainly doing Clomid cycles for poor ovarian responders, and we started with only that indication. Our pregnancy rates in the first 6 months were very low, about 26.2%. But as the embryologists got the hang of vitrification, our pregnancy rates started going up. And within a year, we had added to the indications. Women with poor ovarian reserve is what we had started. We went on to previous IVF failures, women above the age of 40 and women who were previous hyper responders. Then we further expanded the indications of IVF Lite to severe endometriosis, obese women, and resource poor patients. Today, almost all indications of IVF we can use IVF Lite with very good results at a minimal cost. So this was the Rotunda IVF Lite stimulation protocol modified from Cato's protocol in 2011-12. We did a study in 2011-12 where we pooled the embryos without Pgta and compared that to a conventional GnRH agonist protocol. Let me take you straight to the tables which are important. One arm was poor ovarian responders with the IVF Clomid protocol, and the other was the conventional IVF stimulation protocol. Please look at the clinical pregnancy rate per patient. It's exactly twice of conventional IVF. We were very heartened with this, and then we expanded the indications. Look at the number of cycles required to accumulate minimum 6 embryos in the IVF Lite group. So on an average, we required 3 cycles to accumulate a minimum of 6 embryos. But we required only a single cycle to achieve pregnancy for most of our patients in the IVF Lite group. Number of cycles required to achieve pregnancy in the conventional IVF group was 2 or 3. So the conclusions are very important. Unlike standard stimulation protocols, these Clomid protocols do not require a resting cycle between 2 treatment cycles. Women who are already running a race against time to have their genetic offspring can have back-to-back consecutive cycles and give very good results. IVF Lite gives pregnancy rates better than conventional IVF in patients with poor ovarian reserve. Look at this paper, 2015, Fertility, Sterility. Gonadotropin dose is negatively correlated with live birth rate and analysis of more than 650,000 ART cycles. What this simply means in layman's language is the harder the stimulation, that means the more the amount of injections you use for fertility treatment, the lower is the live birth rate. And this is very, very true. I consider John Zhang as the father of minimal stimulation IVF. We call it IVF Lite. He calls it mini IVF. Basically, it is the same. Do not go by the day 3 FSH value. Do not go by the AMH levels. Yet, if you use cryopreserved embryo transfers, in 2010, they were getting 41%. Today, the results, like I've told you, have reached 60-70%. Another multicentric study from Japan, Daniel Baudry. And if you look at the crude cumulative live birth rate, it's 65% for the younger patients and 5% in 43, 44-year-old patients. Again, this is a paper that tells us freezing eggs is as good as freezing embryos in women aged 40 or older using minimal stimulation IVF. This is a landmark paper. In simple language, I will try to explain. In 2007, in 7 universities in Netherlands, Pgta was introduced. The government offers treatment free to its citizens. The universities wanted to assess the efficacy of Pgta, so they made 2 arms. One arm of patients giving Clomid therapy, the other arm of conventional hard stimulation. This study was terminated prematurely after 61% of the planned number of patients were over. This is the only study in the world which was terminated prematurely on moral and ethical grounds because the researchers found a lower embryo aneuploidy rate following mild stimulation. They did not want the citizens to undergo hard stimulation, conventional IVF stimulation. They said it's not justified. So they did not want to take the study further. They had their answers. This study was unfortunately killed by the pharma industry that sells injections. This is a slide from iGenomics, which tells us the distribution of abnormal embryos after Pgta when you spread them across age groups. So under the age of 35, you have almost 55% abnormal embryos. And when the age increases, 42, 43, almost 90% embryos are abnormal. This is the importance of Pgta or pre-implantation genetic testing for aneuploidy. This is one of my recent editorials, which tells us that the harder the stimulation, the worse is the aneuploidy rate. And for doctors, it's a free to download paper, you can read it. In older patients, lower oocyte yields may represent a more appropriate response to ovarian stimulation, allowing the most competent follicles and oocytes to develop, and thereby reducing the occurrence of embryo aneuploidy. Again, this is for the doctors, but these are various protocols that we have evolved from 2010 at Rotunda and then implemented them in both India and the Dubai practices. And this is using clomiphene and 150 minopure. This is clomiphene and 75 minopure. This is only 60 IU, 70 IU of gonadotropin every day. And this is only clomiphene citrate. And so what is the UAE, Dubai IVF Lite experience? Minimal stimulation protocols can be done consecutively till we collect 6 to 7 biopsied blastocysts. We vitrify and accumulate oocytes. Initially before 2018, we were not allowed to freeze embryos. Today we are. A single euploid embryo post Pgta is then transferred in a remote cycle. We have got consistent clinical pregnancy rates in excess of 60%, even in the classical poor prognosis patient groups over 40 years of age. Recent findings suggest that the magnitude of ovarian stimulation affects the proportion of euploid embryos, and ovarian stimulation regimens for IVF seem to have deleterious effect on oocyte quality and embryo aneuploidy in a dose-dependent manner. Today, we are moving to a global era of single embryo transfers, and it becomes more important than ever to ensure that the single embryo has the highest implantation potential. So for women of advanced age, IVF Lite using clomiphene citrate with Accuvate by repeated mild stimulation cycles with subsequent vitrification of blastocysts combined with Pgta is the only approach now that we routinely employ for not only women of advanced maternal age, but for poor responders, PCOS, previous failed IVF patients, patients with moderate to severe endometriosis, and obese patients.